80 years ago, America stepped one foot out of the Depression and right into World War II. In order to avoid the looming threat of inflation that came with the sudden change in available workers back home, the government placed a cap on wages, but they let businesses offer employer-sponsored health insurance to attract employees. While this resolved the immediate problem in 1942, it created a whole new problem in America. Job lock. Fear of losing health insurance coverage caused more folks to stay in jobs that weren't right for them, or set aside dreams of starting their own businesses because of the exorbitant cost of self-insurance. By 2009, a report found job lock cost U.S. workers an estimated $3.7 billion a year in foregone wages. This is MinCentral Currents. I'm your host, Teresa Meese. It took nearly 70 years to see a significant change in the way Americans receive health insurance coverage. And even with passage of the Affordable Care Act, Obamacare, there's room for improvement. The number of uninsured Americans fell by 20 million after the implementation of the ACA. That is, until 2017. Since then, the uninsured rate has slowly started to climb again. Americans need access to health care. So how do we find coverage that takes into account the needs of the patient while also honoring the work of the doctors? My first guest will tell us about her struggles over the years trying to find coverage for herself and her children.
So my name is Renee Carterell, and I live in Annandale, Minnesota. And I have a long history around having problems accessing healthcare. When I first started out in the work world, I worked at a corporation, and the corporation provided excellent healthcare. That was way back in the 1990s. In fact, both my children were born while I was on that healthcare system, and I only had to pay $100 for each of their births, which is amazing. Today, it is much more costly. So I really was provided very excellent healthcare by the corporate world back in the 90s. But in the early 2000s, I decided to leave the corporate world, and I went to a smaller nonprofit. And after I was working there, I realized that they were not offering health insurance to my children. So they gave me health insurance, but my children did not have any health insurance. And of course, I was kind of panicking for a little bit because as a parent of two young children, they were only, like 3 and 5, I was very worried about how to get them health insurance so that I could get them health care. And luckily, Minnesota provides a safety net for its citizens in the form of Minnesota Care. So I quickly found out that I could enroll my 2 daughters into Minnesota Care, and mostly because my income level at the nonprofit I was working at was fairly low. So because of my low income level and because my workplace did not offer health insurance to my children, I was able to enroll my 2 children into Minnesota Care. That worked really well for quite a while, and I eventually left that nonprofit and moved to a part-time position with a brand new nonprofit who could not afford health insurance for anyone on its staff. And at that time, I went on to Minnesota Care with my children. And this worked out really well. Minnesota Care was affordable. I paid a premium every month, just like everybody does. I paid for certain office visits, like emergencies. I had a copay, those sorts of things. I couldn't get the world on Minnesota Care, but I certainly was getting good coverage. My children and I were on Minnesota Care until my new employer, the nonprofit I was working for, was able to establish itself a little more. And eventually, they were in a position where they could offer my whole family health insurance. So my family was eligible for health insurance through my workplace, My workplace was willing to pay for health insurance, and I was the executive director of that nonprofit at that time. So it was my job to go out and find the health insurance. And because my workplace was offering me insurance, I could no longer receive Minnesota Care. So I went out to look for health insurance for my family through my workplace, and I was shocked to find out that I was not eligible for health insurance through the marketplace. And this was back in 2010 or so, 2012 maybe. It was before the Affordable Care Act. I asked the insurance companies why they would not provide health insurance to me and my family. And what it boiled down to was that I was in the early stages of menopause, and I had some of the more common complications that come along with menopause. Very common, simple complications, but sometimes they lead to a hysterectomy. And the health insurance companies simply didn't want to have me on their health insurance because I might be a candidate for a hysterectomy. And so they refused to insure my family as a whole. So I was unable to access health insurance. And once again, we were without health insurance, my family. And my daughters were teenagers at this point in time. So I was really upset about this at this time. It's very frightening to be a parent and to think that your children could be in an accident or get sick and not receive the care they need. The Affordable Care Act was passed soon after that, and my children were one of the millions of people in the United States who were able to get health insurance through the Affordable Care Act. Because once they dropped that pre-existing requirement, even a simple one like going through menopause, once they dropped that pre-existing requirement, I was able to access health insurance for me and my children. Since then, I've had other situations where my jobs have changed. For a while, I was unemployed, and I found that Minnesota Care has always been a very reliable backup for me. I've always been able to access it, often because my income level falls within the right range for Minnesota Care. Minnesota Care is not the same as like Medicaid, which requires you to have a very, very low income. I had a moderate income. So Minnesota Care provide that gap between a family who, for instance, was so low income they were on Medicaid, and a family who had such a high income that they could afford health insurance through the marketplace. So I had sort of that middle income range where I couldn't afford to buy health insurance on the marketplace, but I wasn't eligible for Medicaid. So it has provided health insurance for my family off and on for a number of years. I'm on it currently. My daughter, who is now an adult, she's in her 20s, lives in South Dakota. And South Dakota has a system where they do not pay state taxes. But what she has found when she's unemployed is they also don't have any services. They have no safety net. So when she's unemployed, she goes back off from health insurance, and she has spent a lot of time off from health insurance because even when she gets a job, the job takes 3 to 6 months to get her onto health insurance. So she's been uninsured more often than not in South Dakota. This is something that concerns me for her. She hasn't had a lot of medical needs, but she does have some medical needs that she has had to do things like go to other places such as Planned Parenthood to get birth control or other places where she can access some health care, and she's had a lot of her health care needs unmet. So I'm really grateful for the health care that Minnesota Care provides in Minnesota and for our system that allows us to have that type of health care. This is why I'm volunteering with Healthcare for All Minnesota. It's an organization that is fighting to help everybody have health care in Minnesota. They want to see health care happen for you. They want to make sure those farmers out there who are struggling to pay the really high premiums for health insurance, they want to make sure that they get a fair and reasonable health care plan that will allow them to get their needs taken care of. They want to make sure families like mine, who were always in the middle range of income, we didn't have high incomes, we didn't have low incomes. Working in the nonprofit world, that often happens. And they want to make sure we have health insurance that will allow us to get the health care we need.
Thank you again to Renee Carterell. You can find out more about Healthcare for All Minnesota by visiting hca-mn.org. My next guest joins us to talk about the Minnesota Health Plan.
I'm John Marty, a state senator from Roseville, Minnesota.
So why don't you start us out with the elevator pitch for your plan?
Your elevator pitch is that I think healthcare is something everybody needs, everybody ought to have. And it's a shame we are the one developed, industrialized nation on the planet that doesn't provide healthcare to everyone. And we do it in order to save money. We don't cover everyone and we don't cover everything. And I think that's a mistake. And the reality is we're spending twice what other countries spend per person on healthcare. And so I'm confident and believe the smartest way to do it is, instead of having all these barriers to people getting care, have to have the right insurance plan, have to pay the copays, deductibles, have to go to the right providers that are in network, have to get the right kind of care. Dental is often not covered. A lot of other things aren't covered. That we ought to recognize that the simplest, smartest way to take care of people is to have a healthcare system that covers everybody for all their medical needs, where they get to choose their doctors and providers, and medical decisions are made by those doctors and the patients, not by insurance companies, not by government, not by employers. And the reality is, doing a logical system like that is actually cheaper than what we have in our country.
So I'm curious to know if you have a background in medicine. I know that you've put a lot of work into this plan, so I'd like you to share with the listeners why you're so passionate about this.
Sure. I've been a state senator for a long time and a long time advocate for this. I simply believe that it's a mistake to not cover everyone. And the illustration of when people say, well, what people should feel about universal health care and a Minnesota health plan. And that is when we're really urgent to get some medical care out to people and we don't have time because we got a crisis, we got to do it as simply and efficiently as we can. We do it the way we've dealt with COVID shots and COVID vaccines. Both of those, there was a huge shortage of at the beginning. But in getting them, the difficulty was getting access to enough of them. But once we had them, the one thing that was the most simple of all, I got my first shot recently, and they didn't have a copayment. They didn't have a deductible. I didn't have to have an insurance plan that covered it. I didn't even get what they call an estimate of benefits, the so-called bill we receive. I'm not getting any bill from it. Neither will you. Nobody does, because we want to get health care to everyone. And the smart, simple, efficient way is have universal care where everybody pays into it, because we all pay for it and everybody's covered by it. And it ought to cover everything. So that's how I got into it, just a belief that we ought to have health care for everyone, and believing how ridiculous our current system is, where we put barriers, intentional barriers, between people getting care just so they won't overuse healthcare.
So could you explain how the Minnesota Health Plan is structured?
Our plan would cover every Minnesotan, regardless of age or medical condition or anything else. And it would cover everyone. And people would use the same doctors, same dentists, same everybody else they use now if they want. If they want somebody else, they could go to somebody else. And we all pay for it. Right now, half of the funding, more than half the funding for Minnesota Health Plan would come from government, which already pays for it. We already are paying more than half the dollars spent on healthcare in this country are paid by state and local and federal government. And so we would continue that, but then the rest of it would be paid for. About a quarter of it's currently paid for by businesses, a quarter of it's currently paid for by individuals. And so we would have, instead of employers having to shop for new plans for their employees each year, we'd be having them pay a tax, a business tax for healthcare. And for individuals, we'd be paying premiums. But the premiums would not be based on how sick and your age and how bad a condition you're in. They'd be based on ability to pay. So everybody has to pay into the system. but nobody's taxed more than they can afford, in effect. It's a logical way. The premiums we pay would be based on ability to pay, not age and medical condition. So that's how we pay for it. And again, every doctor, every clinic, every pharmacist, everything would be covered. And you choose the ones you want, and you and your medical providers are the ones who make the decisions. You don't have somebody looking over the shoulder with got to get prior authorization before the doctor can do what they think they need to do for you.
Who would you say are the biggest supporters of this plan?
Most strongest support for this tends to come from people who want medical care. A lot of doctors and nurses are on board. I'd say years ago, American Medical Association was strongly opposed to something like this. But there was actually a poll in Minnesota about a decade ago said majority of doctors actually supports this kind of way where instead of dealing with insurance companies, instead of dealing with all these other payers and the whole administrative mess, that they simply provide health care. So I'd say they're the biggest supporters in many ways.
I understand that some pushback for plans like this comes from providers who worry they won't be properly compensated for their care. Have you taken that into account in this plan?
When we designed Minnesota Health Plan, we based it around 10 principles. And we actually make those principles legally binding on it. And one of the principles is fair and timely payment of providers. Another one is that we have to make sure that we have sufficient providers to meet the needs. When we talk about rural communities, there are many of them that are greatly underserved. And under this plan, the plan would be required to do it. They may have to pay more to get a doctor to practice in a small town than they have to pay to practice in the metro area. Just because, if you're on call in a medical system in the Twin Cities, you might have, if you're in the kind of practice where you have to be on call once, so it might be one night a month. If you're in a small town, you might be on every weekend, you might be on call at night. And so we want to make sure there are enough providers to do that. You may have to pay more in that way. So the health plan would be legally bound to addressing those shortages. And like rural hospitals, some people say, oh, if you had a universal healthcare system like that, it's going to be, rural hospitals can hardly make it now. Well, they're not making it now. We're saying by putting hospitals on a budget, each one on a budget, like a school has. You set a budget each year. If there's a crisis, pandemic, something else that hits them hard, you have to renegotiate in the middle of the year. But they will operate off a budget instead of billing all their patients. And rural hospitals be far better off under a system like this, which would be determining hospital need based on population and public need, not based on somebody's business model. Because under the current system, these big Sanford and Mayo and Essentia and all the health plans, all the hospital systems, they all buy up more and more hospitals. And like Fairmont, Minnesota, several years ago, Mayo shut down the hospital. They cut the Albert Lee Hospital hugely in size and what they cover. And that wasn't made based on the needs of the people in Fairmont and surrounding communities. It wasn't based on the needs in Albert Lee and communities around it. It was based on somebody's business model. And under our plan, we'd be basing the need on what's out there. And so, yeah, you can't underpay people and have a workable system.
So how is it looking in the legislature for moving forward with this bill?
It's the Senate majority. I'm in the minority now. Senate Republicans in the majority have not been hearing bills like this. And so it's not going to move this year. I know that. I was not expecting it to. But I think as we have a growing crisis and the only solution they've been able to come the last several years is, well, under our current system, we're having trouble getting, some counties have at most one insurance company willing to cover them. And so we're going to provide a subsidy for insurers. We're going to reinsure the insurance companies. And to me, that sort of speaks volumes for how far out of whack our system is.
So in your opinion, what are the biggest selling points for your proposed plan?
I point to the two biggest savings. The first one is administrative. And for this, maybe the simplest way without charts and figures to show this would be to use an analogy between the way we pay for healthcare and the way we pay for public education. If we were to just imagine for a minute, if we were to fund our schools the way we fund our hospitals, Every kid who goes to school would need to pay the bills. Their family would have to pay the bills. And education, like healthcare, is very expensive. So you'd need health plans to cover the bill. You need education plans. Education plans would be very expensive because of the expense. So employers who care about their employees would start offering employee benefits for education for their kids. And then you'd have plans like Blue Cross might have a Blue Plus for education. Health Partners, another big one, might have education partners. UCare might have a ULearn. Medica might have an Educa. I mean, just think of those are some of the big plans we have in the state. We could have all those, and for every kid. And at school, what difference would it make? Well, every day, each teacher would have to spend time at the end of each day calculating how much time he or she spent with each student, how many supplies were dedicated to that student. And this isn't uniform. You got to understand kids with special needs may have a paraprofessional with them half the day or all day. Some kids are going to be far more expensive, but the teacher has to document this and sends it to the billing office. And I don't know any community in Minnesota, I don't know any school in Minnesota that has a billing office. And the billing office would then gather all the overhead and utilities and administrative costs and fold it in. Then they'd send out regular bills to the students' parents and their school plans. And every you have to pay that. And then every year the employers would have to shop for a new insurance plan for their employees because the factors are changing so much each year. They got to get a better price because it's so expensive. Parents would have to be writing out monthly premium checks, and they'd have to write their co-pays and deductibles out. They'd have to make sure their kids' teachers were all in network. And there's a lot of problems with this. First of all, the cost. Think about how much more expense we'd have for all these education insurance plans. Using that analogy, that's a long analogy, but use that analogy to see what that means for our insurance system, our health insurance system. So huge administrative savings on this. And the other part of it is price negotiation.
And what would that look like?
I said, I think some doctors and medical providers have their payments, their rates go up. Some would have it come down, but it'd all be negotiated. Under our current system, it doesn't work that way. Take pharmaceuticals. Things that cost several $100s now for a month's supply, like insulin, used to cost like pennies on the dollar, literally. And some drugs, there was one that would eliminate, wipes out hepatitis C. Cost of a treatment course in the US was like $81,000 for a month of the pills to get rid of it, and then you're done. So it's good, but $81,000 for the course of treatment, that would bankrupt us if a lot of people needed that. But if I told you that some other countries you could buy the same course of drugs for $900, all of a sudden it looks a lot more reasonable. That price disparity is incredible. And it's not just prescription drugs, which desperately needs it. But again, under current federal law, Medicare Part D is not allowed to negotiate. It is prohibited by Congress because of drug lobby clout. They prohibited federal government from negotiating those prices. So in effect, 20 years ago when they offered prescription drug benefits for seniors, they effectively said to the drug industry, okay, whatever drugs our seniors need, we're going to buy them. Could you tell us how much we should pay for them? Because we're not going to negotiate. You just tell us how much you want us to pay you. That's the way we do it. We need price negotiations. And for other expenses, hospital types of costs, knee replacement, a basic knee replacement, not a hip and knee or something else, but just a simple knee replacement. There was a study done by Yale University about 5 years ago now that found the cheapest hospitals in the country for it were about $3,500 for the surgery, I think $3,400. And the most expensive hospital for the same surgery was like $55,800 or something, which, if you do the math, was at the time a 16-to-1 price disparity. Now, you know how to negotiate prices if you buy a product like a car that you negotiate prices on. You might, if you're a good negotiator, if you're a tough negotiator, and a lot of people pride themselves in that, you might save 5%. I don't know, maybe if you're really lucky, you'll save 6 or 7%. But you don't save yourself 1,600% by shopping around. That's the point. We don't have a fair, logical pricing system. Is the hospital doing it at $3,500? Are they losing money on it? No, those are the prices they set. It's not like it's a loss leader. This week we're going to have a special on knee replacements. Get your knees replaced. We don't do that. It's simply we have no good price negotiation mechanism. And the insurance companies who should be doing that, we think, but there are a lot of reasons that doesn't actually work that way. And so the two biggest savings, this is a long answer to it, but the two biggest savings are one, the administrative expenses, as you can see in the school analogy, and two, the price negotiations.
Are there any misconceptions about this plan that you'd like to use this time to address?
Sure. The biggest argument I hear people talking about who are concerned about is going to be government-run healthcare. Matter of fact, about 4 years ago, when we had the few months after Trump election, I wasn't going to do anything with it, but some of my colleagues said, "Why don't we have a news conference and just make the pitch for it?" And we decided to do that. And in preparing for it, I said, "I bet you I know what the first question is going to be." And the question would be, didn't the voters just say they don't want government-run healthcare? And aren't they going to hate your system? And I said, well, first of all, I'd say this isn't what I'd call government-run healthcare. I'd call this patient and doctor-run healthcare. Who makes the medical decisions? Well, who chooses which doctors and providers you go to? You do. You choose them, and then who makes the decision? You and your doctor. Not the insurance company, which is what happens most of the time now. Prior authorizations, what doctors are in network, everything else. The government does the same sort of thing with it, but they've mostly turned it over to insurance companies now and employers. They tell you what you have to do. The Minnesota nurses have actually gone on strike in the past because one of the employers, Alina, was telling them, you have to get your care from these doctors and this plan and this sort of thing. And they're saying, hey, we're willing to pay more for this if it costs more, but we want to do it this way. We want more choice of how we do things. If you talk to doctors who deal with patients in certain types of conditions, you'll say they spend countless hours, sometimes the doctor themselves, and certainly their staff, on the phone with insurance companies arguing for prior authorization to do certain procedures. And to me, that's not patient doctor-run healthcare. That's, if anything, it's giving insurance companies a license to practice medicine. If you're my doctor and you say, I think we need this procedure done, the insurance company says, you need prior authorization for that. Then you have to go there and they're telling you, they've never seen me as a patient, but they're telling you what kind of treatment to give me. And I've talked to some doctors who say how much time they waste on that, either on specific drugs or certain treatments they want to provide. And the insurers and it takes a lot of time, and it's not better for the patient. It's not intended to be better for the patient. It's intended to be cheaper for the insurance plan.
In our current environment, a lot of health insurance access is tied to employment. How would this plan change things for businesses and workers?
Well, I was on a panel with several on healthcare for employers a few years ago, and one of the fellow panelists was I guess you'd call her the CEO or president of a small business. She said it was only like 7 employees. And she says, yes, she cares deeply about her employees and she's provided coverage for them, but so on. And she says, it's just so much paperwork and trying to figure it out and negotiate it every year. And I said, every employer I talk to talks about the stress and the headache of doing that. Could you quantify how much time you spend on this? She said, at least 4 days a year. She's real small, tiny business, and she's doing all that work herself. She said, at least 4 days a year, and she said, and 2 sleepless nights. She said that she's just worried sick over it. And to me, yeah, she'd have to pay something for this, but just not having the worry, and not only just in picking the plan, but the employers who do find the plan, every year they have to tell the employees, well, this year you can't get this and you can only go to these doctors and you do this. Boy, it's just not a good way to do it. You want your employees to be covered and treated. And the other thing is when you're hiring somebody, if you're an employer that provides coverage to employees, if you hire a 25-year-old instead of hiring a 64-year-old, you're going to be paying about a third less in premiums, which would be age discrimination. But, if it's the only way you can afford insurance, we don't have to worry about that. Upon a land like this, everybody's covered, and you don't have to worry about what their premiums are. If you were going to cover it, you have some, as I said, you'd have either a payroll or some other kind of tax. We have yet to figure out how to do it best. But you don't have to worry about teaching them how to use it. You don't have to worry about which employees you hire and everything else. And it's not just your employees, it's your employees' families, because if your employees are tied up because their spouse or kids are sick, it interrupts their work and their ability to help at the business.
What would the health insurance landscape look like for folks who currently get their coverage through self-insurance?
I have heard from so many farm families where, we're both needed on the farm, but one of us has to work in town because we need the benefits. And what a waste. And one other one on the same model is the stereotypical entrepreneur who's got some great new invention. They're working in their garage or in their basement to develop this product and bring it to market. You heard these stories, people working 80 hours a week on it. But that's not true so often anymore. Now they're usually working as many hours as they can, but they're working 40 hours at another job, so they have benefits. Just think what we would have if we would have it. I'm not arguing this is cheap. I'm arguing it's less expensive what we got now. But think of those other benefits for the farm families, for the entrepreneurs who could devote their time to it, to the people who are stuck in the wrong job, to all the hassles of this. And a couple of years ago, 2 or 3 years ago now, I think it is, Warren Buffett, when he has his annual Berkshire Hathaway shareholder meeting, he always gives talks about various things. And a few years ago, he talked about healthcare. And he said in 1960, I guess he would have been a fairly young businessman at the time. 1960, he said, we were always complaining about corporate taxes. They were, what a burden that was. And they were about 4% of the economy at the time. And he said, we've been complaining for 50, 60, 70 years now, 60 years now. And now it's down to about 2% of the economy. So we've been complaining. We still complain about it. He says healthcare back then was about 5% of the economy. And I'm sure we complained about it some now. Now it's like 17 going on 18% of the economy. And we still complain about it a little bit too. But he described it as the tapeworm that's eating away at the economy from the inside. Is a good graphic illustration, I guess. But he said that, why aren't we doing something? He says we penalize our own businesses by forcing them to deal with this. And it's out of control. And again, most of the efforts, the reason of our complexity in this screwed up system is largely because we're trying to save money. We're not trying to develop a healthcare system that makes sense. We're trying to develop a healthcare system that doesn't cost as much. I'm very troubled by all these reform efforts that figure out we put more paperwork in and somehow we're going to save money. And one other thing on this too, when we're talking about what people object to in it, they're convinced if we're going to cover all people for all their medical needs, and we're not going to put all these barriers like copays or deductibles or networks or prior authorizations or whatever, we're not going to put that in. We're going to make it easier for people to get health care. People are going to go hog wild and they're going to consume untold amounts of health care. And I know a lot of people who would get a lot more health care, but only if they're not getting enough. And if people are not able to go see the dentist, as soon as you start covering dental care, everybody's going to want to go see the dentist because they need to. But that doesn't mean people want to go and get health care just for the sake of getting health care. Let's use the illustration, hey, I got next Thursday afternoon open. I think I'll go get me another colonoscopy. That was so much fun. I mean, who does that? Oh, yeah, I want a knee replacement. I like a shiny new silver knee or something. Yeah, no, nobody does that.
Do you have any closing thoughts that you'd like to share with us?
Sure. The biggest criticism I've heard of the Minnesota Health Plan over the last 10 years is it's not going to happen. You can't change it. It's too big of a change. People are never going to support that. And my response is, wait a minute. First of all, we don't have a choice to continue what we're doing. We're bankrupting ourselves. It's growing. Costs are growing faster than inflation. It's already more than a sixth. It's going on a fifth of our economy. is going to healthcare. It's leaving lots of people out. We have far worse health outcomes than people in most industrialized countries. We're better than like Mexico, but not much kind of thing in terms of life expectancy, things like that. And so we really need to change. And so when people say it's not possible to change, I just say, no, I don't buy that. I cannot accept it. I'm a believer that Minnesotans can come up with a different solution, a solution that works for all of us. And so that's why I'm going to keep pushing it, because I absolutely believe we could make this happen.
You can read more about the Minnesota Health Plan at mnhealthplan.org, where you can also download a copy of Senator John Marty's ebook, Healing Healthcare: The Case for a Common Sense Universal Health System. With your help, our audience has been growing. Every time you share an episode, we reach new listeners who will hopefully be inspired to engage with new ideas and organizations in our community. Thank you so much for supporting local independent journalism. This episode was developed and managed by Renee Carterell. Production by me, Teresa Meese. Music provided by Epidemic Sound. Contact us with your questions and comments at MinCentral Currents. That's MINN Central Currents with an S at gmail.com. You can find us on Twitter, Facebook, and YouTube by searching for MinCentral Currents. Till next week.